to you live from San Diego, California, where it's 6 o'clock in the morning. We have people listening to us all across the country, in Ohio in the United States, where it's 9 o'clock in the morning, in New York, where it's 9 o'clock. We have people all across the continent, in Canada, in Vancouver, in Toronto. We have people all across the globe, in Central America. Our friend Angela Fernandez is in Colombia. We are in Brazil, where Mauro Goldschmidt is. We're in Argentina with Fernando Prieto Diaz and his friend Susana Gaimo. We are across the ocean in London, England, where we have two people from the UK who will be joining us today. In Paris with Dominique Thouvenin. We are in Italy with Max Serafino and Paolo Nucci. We are in Germany. We are in Switzerland with Daniel Mohan. We are across Europe. We are in Greece. We are in Romania. We are in Russia. We are in the Middle East, in Iraq. We are in Lebanon with Mohammed Yunus. We are in Egypt with my friend Mahmoud El-San. We are in Israel with Yair Marad. We are in Saudi Arabia. We are in Africa with Professor Adeo Dio. We are in South Africa with Nicola Freeman. We are in Asia. We are in India. We are in Singapore with Liao Xiaowei. We are in Hong Kong with Connie Lai. We are in Australia with our friends Craig Donaldson, Lionel Covell. We are in New Zealand with Schwan Dai, with my friend Brenda Bridenstine. We are in the PI with a whole bunch of fabulous doctors that are there, and I say hello to. And it is early morning, 3 o'clock in the morning, where Jean Shen and Malcolm Ming might be in Hawaii. Welcome to Around the World. We have some housekeeping duties for this worldwide webinar brought to you by the World Society of Pediatric Ophthalmology. This is episode 7, Esotropia, the Great Debate. We've been discussing this for a long time in our field, and we'll hear experts talk to us some more today. But first, I want to remind you of a couple of things as we go along, because you're listening in Spain, you're listening in Austria, you are all over, and we need your input. And as we do so, we want to get everyone logged in immediately to the menti.com site. That's menti.com. And on menti.com, you can log in using the menti.com code that we have for you today. And that code is 996550. You will be asked questions that you can respond today. During the debates, we're going to ask you what you think, and then if you changed your mind as we went along. Menti.com, 996550. We look forward to hearing your input. Don't forget, on your site, where you are right now, if you're on Facebook, if you're on YouTube, talk to us. Tell us where you're from. You're going to have some very special people who are engaging in discussion with you right now. They'll be feeding us your questions. If you're on the Bluetooth platform, my co-moderator, Rich Hertle, who I'll introduce in a moment, and I will be getting your questions directly for the panel. And at the end, if we don't answer all your questions, this group of doctors, this group of specialists, this group of people who you're going to be hearing for the next 90 minutes will answer your questions, and we'll have it in writing. At the end, when we're done, we will be giving you a survey. That survey will allow you to give us feedback on how we're doing. What could we do better? What would you like to hear that you haven't heard? We want to hear that from you. And it will allow you to get the PDF feedback of all the webinars that you've seen so far with all your questions answered. One other housekeeping thing that we need to get through, and that is, as you may have heard, ESCRS, URetina, UCornea, and WSPOS are going through a change for our next large meeting. The world is different than it was. In an abundance of caution, we're shifting to a kind of meeting that you've never had before. It's not just a virtual meeting. It's not just going to be an online meeting. You're going to have the opportunity to be part of the first WSPOS Worldwide Connect. WWW Connect, because we connect the world. Stay tuned. Watch our website. Watch the listservs. Watch the Facebook page. You will hear what we're going to do. It's nothing like you've seen before. All right, enough of that. Now, after we thank NTOD for giving us a platform that we can do here, let me introduce some of the people that you're going to hear today. First, Jan Rolf, J.R. Polling. He's from the Netherlands. He is a senior lecturer in orthoptics at the University of Applied Science in Utrecht. He's getting his PhD, and bravo for that, and he specializes in myopia and genetic syndromes. He was elected president of the IOA in 2018. JR and his co-discussant, Tony Vivian from the UK, who's a pediatric ophthalmologist. He's an adult strabismus surgeon. He's at Cambridge Hospitals. And he's the past president of BIPOSA. They will be discussants today who will be probing our speakers in the debate to really test whether or not they can support what they've said to you. So we're counting on those two to get us through. Additionally, my co-moderator and friend, Rich Hertle from the United States of America, who truly does not need an introduction. But what you may not know about Rich is that besides nystagmus, he's been involved in hockey for over 45 years. That's ice hockey. He played even at the Ohio State University. Rich Hertle and I were chosen for this because we have known each other for, I think it's 30 years now, Rich. And I'm pretty sure during that whole time we have been debating strabismus. So it was perfect for us to do this together. So Rich, I'm going to hand it over to you to introduce the rest of our speakers and introduce our entire debate. Thanks, Rich.
Thanks, David. Good morning. It's a real pleasure for me to be here and to represent WSPOS in this novel endeavor, which each session becomes more incredible and more successful, and we learn how to do this better as we do this with all of your help. So for the next person that will be involved here is Kim Tan from Australia, who's the head of the Department of Ophthalmology at Sydney Children's Hospital, and he's a lead visionary at their hospital for a pediatric ophthalmology site for all. Next is Daniela Cioplean. I hope I said that, Daniela, from Romania. She's a consultant ophthalmic surgeon, a lead clinician in the Strabismus Oftapro Clinic in Bucharest, Romania. She's the ESA vice president and former ESA editor. She's the co-founder of the Romanian Society of Strabismus and Pediatric Ophthalmology and its ex-president. Thank you, Daniela. Next is Dave Granet, who you all know, and his lovely family, who I miss tremendously because they're on the West Coast, and one of his sons is across the pond in England, and one of his sons is an excellent hockey player. So I think that was transmitted via his uncle Rich, not from his dad.
I don't play.
And this Dominique Thouvenin from France, who's a strabology and pediatric ophthalmology unit at the Clinique Rivet Gaucher, Toulouse, France, at the Université Hospitalière in Perpignan, the School of Orthopty at Toulouse, the ex-vice president of ESA and AFSOP.
Rich, you can tell that Americans tend to speak one language and everybody else is way ahead of us.
Right. And from India, we have Meenakshi Swaminathan, and I know I butchered that one. She's a musician, a birder, a chef, and a poet, and she's American board certified. She did her fellowships with Bill Scott and the late Ron Keach. She has an academic practice in India, and she's also a residency and program director over there. We're happy to have Meenakshi here with us. And Manoj from the UK, who's a consultant ophthalmologist at the Birmingham Women's and Children's Hospital and Oxford University Hospital in the UK. And Chong Bin Tsai, Taiwan, Chong Bin Tsai from Taiwan, who's the attending physician of ophthalmology and past vice president of the Chai Yi Christian Hospital in Taiwan, and assistant professor, Department of Optometry, Asia University in Taiwan.
So don't forget, we're going to have a survey for you afterwards, but now I'm going to stop sharing my screen and remind everyone to please go to menti.com and put in your code 996550 as we begin this. We want to make sure that you have a chance to answer the original questions. I'm going to run through those right now to make sure that you can, as Chong Bin get ready to start, so that there's no doubt you're answering the questions right now. As we get ready to begin, we're putting in where everybody lives as we go, and then we are going to.
Can you hear me now?
Sure. show, yes, you can. One more second. I have to get everyone to ask whether or not what they do as we do your, get ready for your questions. So they're answering right now whether or not they're fellowship trained. And shortly, we're going to go over to the last question before you start. And this is, what is your preferred treatment for infantile esotropia? And we're getting answers to that right now. Not going to tell the panel what they're saying yet. While that's being answered, Chong Bin, you can go ahead, and I'm looking forward to hearing what you have to say.
Okay. Thank you, David. Today, I would like to talk about the treatment of infantile esotropia with botulinum toxin, Botox for short. Okay, when you see a baby like this, there are several factors to be considered. All pediatric ophthalmologists agree on the concept of early intervention to improve binocular vision. However, it's difficult to obtain the reliable measurement in infants. Besides, the patient's parents often express their concern about the risk of exposure to general anesthesia in the children. When the ET angle is large, there is a certain percentage of delayed overcorrection after large amount of medial rectus recession. Do we need to treat the possible coexisting IOA or DBD at the first surgery? Did the ET have a accommodative component or high ACL ratio? Since the patients of infantile ET often experience many times of surgery during their lifetime, we wish to reduce the number of surgery as much as possible. Considering this factor, I prefer Botox injection as the primary treatment for infantile ET. Our protocol is as following. The patients receive general anesthesia using mask inhalation without intubation. The injection is performed transconjunctivally without EMG. We use 5 units of Botox for all angles. The injection time is within 1 minute, and the time under anesthesia is no more than 15 minutes. And this video shows the technique of injection, which was modified after a component technique. We use 2 forceps and to abduct the growth, and then firmly grab the injection of the medial rectus with 1 forceps, and then hand over the injection to the other forceps to make a gap between the tendon and the sclera to allow passage of the needle. Now we can pass the needle through the gap and advance tangentially to avoid penetrating the growth. And then we rotate the globe and change the needle into a perpendicular direction parallel to the medial orbital wall. Now we can inject the Botox and retrieve the needle after injection. Our result shows that using Botox injection as a primary treatment for infantile ET shows that in a case series of 13 patients with average follow-up of 15 months, the average total number of injections was 1.5 times. The average interval between injection was 4.8 months. The average age of first Botox injection was 18 months, and the average age of muscle resection surgery, if necessary, was 34 months. In the case series, 50% of patients did not need muscle resection surgery. The average ET angle at initial visit was 46 Fresnel diopter, and the ET angle before muscle resection surgery, if necessary, was 31 Fresnel diopters. We can see the benefits of Botox injection that many children may skip an unnecessary surgery with Botox injection. And if surgery is necessary, the children will grow older, that the measurement can be more reliable. As the ET angle becomes smaller, the amount needed to muscle resection can be reduced. Our result is similar to a previous report. The author reports stable result of 51% of cases after a single Botox injection. And for the rest, 49% of cases requiring surgery, the deviation angle was smaller. In the meta-analysis review of 9 studies, the group success rate was 66%. The mean change of deviation after Botox was 30 Fresnel diopter. The review demonstrated the efficacy of the Botox injection in infantile ET. Therefore, I prefer Botox injection as a primary treatment for infantile ET. Thank you for your attention.
Thank you, Chong. That was excellent. Very, very well presented and good, excellent data. Next up is Manoj, and he's going to be for surgery.
Chong Bin, can you stop sharing your screen, please?
Yes.
Great. And so as Manoj comes on, we should take just a second and remind everybody of what our format is. Each presenter is going to have about 4 minutes to make their case in infantile esotropia about what their treatment might include. And this time we're doing botulinum toxin as a primary treatment. We're getting questions on Blueberry already about this. It's a primary treatment versus surgery as a primary treatment. Chong Bin is laying down the gauntlet. Manoj, you're going to pick it up and respond. This is your moment.
Manoj, you need to unmute.
Manoj, I think you're muted.
Can you hear me now?
Yes.
Brilliant. Thank you. So thanks very much to WSPOS, Rich and Dave for inviting me here. And congratulations to Chong for an excellent presentation. He's made my job even harder. So I'm going to talk a little bit about infantile esotropia. And it's good to start with what we don't know. We don't know if it's a neural abnormality. There's an excellent article by Mike Brodsky referenced below. Why is the angle so variable? Is the potential for developing binocular single vision predetermined? And what is the window of opportunity? So there's lots of unanswered questions. What we do know is that restoring alignment is our best chance. We know that prolonged period of good alignment maximizes the chances of success. We know that there is significant nasotemporal asymmetry, and the incidence of undercorrections is quite high. So let's examine the evidence. There's an excellent paper that's come out in WSPOS recently, which shows that the results of surgery are very gratifying indeed. And I won't dwell upon the timing of surgery. That's the subject of another debate. So it's fair to say that intervention works. Let's look at another paper which looks at bimedial recessions and compares it with unilateral recess-resect. And what they found was that there was significant undercorrection with unilateral recess-resect procedures. And so it follows that the primary focus of our work should be weakening the medial rectus, and that has to be sufficient and prolonged. So there's every reason why most surgeons perform bimedial recessions. So bimedial recession weakness, bilateral medial rectus weakening, we know is a very useful strategy. Now, I can list many more, but I've got a few references which I hope you all can review later, which support the case that duration of good alignment, less than 8 prism diopters, correlates extremely well with good sensory outcomes, which is what we desire in these cases. Now, let's see what happens with botulinum. So this is the typical curve with botulinum. You find that it takes some time to come on, and then it lasts for a few weeks, and then it starts to wear off. And I'm referencing the same paper that Chong Bin referenced earlier, which looked at 9 eligible studies, and they quoted a good success rate. But of course, they had a very low consecutive exotropia rate, but quite a high incidence of ptosis and vertical deviations. And needless to say, it takes some time for these to recover. So we are losing valuable time before the botulinum toxin gives us the desired result. And the mean change of deviation was about 30 prism diopters. So we know for a fact that botulinum toxin cannot correct the full deviation. So fair to say that the initial period is lost, and then as the effect of botulinum is wearing off, that period is lost as well. And the true effective period is down to a few weeks. So surgery provides a longer duration and more consistent alignment compared to botulinum toxin. And a technique that would last longer should give us better results. I'm again referencing the same paper by Alejandra Campomanes and Gil Benenbaum, which had a direct head-to-head comparison between surgery and botulinum toxin. And they had good numbers, 120 cases undergoing surgery and 300 plus undergoing botulinum toxin. And it's evident from this table that the results of surgery were far superior to botulinum toxin. And indeed, I would draw your attention to the fact that the age at surgery was much older than botulinum. So there is a disadvantage to this group, and yet it did better. Fiona Rowe and Carmel Noonan from the UK did some work for the Cochrane database where they looked at 6 randomized controlled trials, and they showed low or very low certainty evidence with varying responses. And interestingly, what they suggested was that increased success with ocular alignment was seen where surgery as well as botulinum toxin was used. So what about the literature? I've given you one side of the story. I will be finishing shortly, Rich. What about literature that supports botulinum? Well, there's 2 very good studies that showed botulinum works, Emilios Campos and Gersa et al. But what Chong mentioned, as well as what's evident from this paper, is that the number of anesthetics that are required is much greater for botulinum toxin rather than surgery. And the number of general anesthetics does carry a risk. So single exposure is not associated with any neurodevelopmental impairments. But of course, multiple exposures to general anesthesia does increase the risk. And of course, there is the additional cost of repeated procedures. And that does need to be factored in when deciding what is the best treatment for these children. So is there a role for botulinum? I think there is. It does reduce the initial angle, but doesn't obviate the need for further surgery. And it could also be a very useful addition to surgery. But I still make the case that surgery remains the primary treatment for infantile esotropia. Botulinum toxin may be a very useful adjunct. And both of these individuals would like you to vote for me. Thank you.
Thank you, Manoj. Thank you very much. Now we have an opportunity for each of the 2 presenters for a minute of a short rebuttal or further discussion. Chong Bin, go first. I think you're on mute, Chong.
JR, you mean me?
Okay.
No, Chong Bin.
No.
Okay.
Chong Bin, you.
Okay, can you hear me now? Can you hear me now?
Yes.
Yes. Thank you for the talk, Manoj. About your presentation, I want it's something that you're talking about the effect of Botox is only a few weeks, that the effective only for a few weeks. But actually, in our clinical experience, it can the interval between the 2 injections about 4 months. So I think that's pretty good. And for the paper you mentioned about that, the successful rate of Botox is 45% compared to surgery. But we have to remember that when Botox is successful, you don't have to have surgery anymore. So that's a different kind of definition of success. And for the and as you mentioned in your talk that the age of the surgery is 27 months old. So that's a bigger child, so we can perform surgery more confidently with the measurement. And actually, it's already beyond 2 years old. So we all want to perform something below 2 years old. So I think Botox has the role here. Okay, that's my report.
Yeah. Thank you, Chong. Manoj, you have a little bit of time.
Yeah. Chong, you made some very good points, and I agree with much of what you've said. I agree that Botox certainly buys us time, but with evidence that accurate alignment early on gives us the best chance of success in the longer term, why not go for something which would give us a very precise result early on, reduce the number of procedures for the child, and try and aim for a sensory outcome, which and again, can I just make one other point? You mentioned about the incidence of consecutive exotropias. I get that, but the amount of surgery that was performed in the paper that you quoted was 7 millimeters, and most of us tend to do less than that, 5.5 or 6 millimeters. So I think it is a safe and very effective treatment with a lower incidence of reoperations. I'll stop there.
Thank you, Manoj. And now I think we have an opportunity for our 2 discussants before the questions. So I'd like to turn to Jan first, JR.
Yeah, thank you, thank you. Very nice presentations, a good overview in 4 minutes. It's really hard to do that. I'm looking into the different studies. I have comments for both authors. I see the different studies, and especially the Botox has a success rate in several studies of varying from 35 to 100%. So that's a little bit confusing. There are limited studies, and I've done some studies myself in infantile esotropia. It's really hard to find patients. We did an investigation or a prospective cohort study here in Rotterdam in the Netherlands, where we investigated 10,000 Rotterdam children. Only 5 of those 10,000 children had an infantile esotropia. So it is difficult to find a proper cure when there's limited patients like this. And my biggest concern, and that is but that goes for both techniques, is the measurement, the pre-op measurement, and the dosing of the surgery. So when we do regular surgery, it's easy to dose, but in Botox, what about the dose response? I wonder this because I'm teaching my orthoptic students to be precise in what to plan for, what to do. And with surgery, we sort of less know because we have 100 years of, or plus experience, but with Botox, it's people need to, or especially the Botox people need to emphasize on the dose response more, in my opinion.
Thank you, JR. Tony, you're up.
Oh, hi, thanks. 2 great talks. I enjoyed both of them. I'm going to summarize slightly a little bit about who said what. So Chong started pointing out to us that we need early intervention in infantile esotropia and showed us his elegant protocol, which was a great video. Thank you. He pointed out that 1.5 anesthetics were needed on average in order to get 50% of cases into a stable zone. Manoj went on to tell us what we don't know and what we do know. And one of the biggest impacts is whether this is a neurological abnormality. As we know, it's more common in children that are born prematurely, which have white matter abnormalities. Are we looking at a neurological abnormality? Unfortunately, we can't treat neurological abnormalities, so whatever the cause, we've got to have a treatment. So Manoj talked about his results of surgery. He talked about which surgery we do, whether we do bimedial recessions or do recessed resects, and that's been a debate that's been going on for many, many years, and studies come out on both sides. I think most of us feel that bimedial recessions are the way to go for a number of reasons. Manoj then pointed out the complications of botulinum toxin, particularly ptosis in almost a third, and then vertical deviations, both of which are very amblyogenic. And lastly, pointed out that surgery lasts a lot longer than Botox and could be a permanent fix. So there's some good points on both sides, and right at the end, both of them pointed out that both treatments simultaneously have a role to play, particularly in large deviations. I think I know what you're going to be asking, you lot, and we want loads of questions coming in, please. But you're going to be asking, you know, how early is early when you're intervening with botulinum toxin? How much damage do general anesthetics do? I'm not sure we know the answer to that. How much surgery do we do? What type of surgery do we do? These are all questions you're going to be wanting to ask us.
Thanks, Tony. We do have a couple of minutes. We didn't start exactly at 9 for the discussion, so Dave, if you have some questions coming in.
Oh yeah, we're getting questions from all across the world, and Ken Nischel and Ramesh Kekanoya are online telling us that we have people from India, Nepal, Australia, Pakistan, Iran, Dubai, Malaysia, Singapore, Israel, etc. The questions that we're getting are things like, if when you do Botox injections, that you're less likely to see inferior oblique overaction. So Manoj, the question for you then is your interventional surgery causing inferior oblique overaction and giving these children an extra problem that they wouldn't have otherwise had?
I think I'm unmuted, so can you hear me?
Yes.
Yeah. So I think there are lots of studies, and I can't reference them right now, which show that regardless of whether you intervene or not, these children will develop dissociated vertical deviations. They'll develop inferior oblique overaction. Some of it will become more evident following surgery. It will become more evident following Botox, regardless of which technique you use. Once you restore the horizontal alignment, the vertical misalignments will start to appear. So I don't think either technique will obviate the need for further surgery to try and correct the inferior oblique overaction in the cases where they develop.
Chong Bin, we're getting some questions about anesthesia. We know that more and more there's damage to infant brains with anesthesia. Do you think that using Botox is protective because you're waiting till the child's older and the young developing brain's not being exposed to anesthesia, or because they have to go in more frequently that somehow it's worse exposing the child to anesthesia? And does it need anesthesia at all?
And yes, we noticed that people are talking about the neurotoxicity of the general anesthesia. And the recent review paper of the 5 years follow-up for the children that under 5 years old and the anesthesia within 1 hour, there's no evidence of any developmental anomaly of the children. But the paper say very conservatively that's for single one exposure on anesthesia, and they cannot conclude about the multiple exposure to anesthesia. So for this point of view, although our anesthesia time is very short, but we still have to reduce the times of exposure to general anesthesia at this moment.
There is this may go, and I'd like maybe Jan and Tony quickly to respond to this, but throughout the entire conference, for all of the discussants and all of the speakers, that infantile esotropia is a spectrum of diseases that may encompass a syndrome from pure horizontal deviation to multiple deviations, vertical, horizontal, dissociated deviations, the associated fusion maldevelopment, nystagmus, and an accommodative component. So there's a population of patients that broadly belong to infantile esotropia that have different brains. And I'm wondering how this could affect the decision-making process, or whether it affects the decision-making process or not. And I think this kind of question may actually permeate the entire hour and a half that we're talking about.
That's such an important thing to say, Rich, because we see deviations going from small, under 30. Is that really infantile esotropia? What are we looking at there when they're small? Up to 80, 90 prism diopters. Is this the same disease? And Botox is quite good at treating small deviations. Is that because it's a different condition? And so I think that's a really important point to bring out, which maybe should be throwing different solutions to different problems.
I believe that I see a lot of ex-premature children and children with syndromic causes. They develop a infantile esotropia. These are totally different than the normal infantile esotropia because of the binocular vision. It's all binocular vision. If there's a potential, if there is no neural or normal neurologic development, there is a potential for binocular vision, and you would see a better outcome either from Botox or surgery. So it's all driven by binocular vision. And I think the children who have a bad prognosis those people, you can just delay either treatment with Botox or surgery. So it's simple, in my opinion.
Thank you. This was
JR, did I just hear you say that it's more about the patient than the surgeon?
No, it's more than the patient or than the treatment, not the surgeon. I wouldn't go
right. There. Yeah, it's not us.
All right,
okay, before we go to the next one, I need to just let you know how the Menti questions have gone. Overwhelmingly, before, everyone went for surgery by about 90 to 10 voting. And now we're going to ask, after hearing this incredible discussion, have you changed your mind? Would your preferred treatment have changed, or is it still the same? So please go on menti.com and vote at 996550, and we'll see if we changed anyone's mind by this discussion. And so far, it's now about 80-20. So maybe a few people are looking at Botox as the votes come in. Rich, you can go ahead and introduce the next discussion as we see how people have changed their mind for surgery versus Botox.
Thanks, Dave. Our next section is the surgery for infantile esotropia, early versus late. And our first speaker is Daniela. Welcome, Daniela. Thank you.
Thank you. Thank you for your invitation. I'm very happy to be here. So I would like to share my thoughts about the early surgery in infantile esotropia. The last century brought us the most amazing discoveries in medicine, which made our life better. Last century, and mostly the last 30, 40 years, demonstrated that early treatment in many congenital disorders can be fixed with excellent results, improving the life quality as adults of those children otherwise in other times condemned to be persons with severe disabilities. This is the case in congenital hearing loss, musculoskeletal, cardiac problems, and other problems with very early onset. We found in the last century that early treatment in many pediatric ophthalmological disorders can help us to avoid blindness or abnormal visual development, as all of you know very well. What about infantile strabismus, especially infantile esotropia? Ward postulated in 1903 that infantile esotropia is based on irreparable defect of fusion faculty. So this problem cannot be fixed, and that makes early alignment useless, because in this case, these children cannot develop binocular vision.
Daniela, I'm sorry to interrupt,
Yes.
but we're only seeing your first slide. If you can use slideshow, we can see all of your slides as you go along.
Yes, I'm so sorry. It's my mistake. I'm sorry. Okay, just a second, please.
Just the way you would do for a normal presentation. There you go. You're now muted, Daniela. Can you unmute yourself, please?
Yes, I'm sorry. Okay. Can you hear me? I'm
Yes.
okay? Okay, I'm very sorry for this.
Nope.
There is a huge research regarding binocularity development in the first months of life, and the impact of early alignment on primates have been done. As you see, there are more and more studies. Also, huge research starting with the early 60s. A lot of clinical research initiated by Kostenbader and later on by Marshall Parks, continued by Steger, von Norden, Birch, Inc., Kenneth Wright, Helveson, Dyson, and many other exquisite contributors. These beautiful articles of Tyson concluded that early alignment in infantile esotropia, especially at less than 2 months from the ET onset, can trigger the cortical connection necessary in the brain in the V1 area in order to develop later on stereopsis at different degrees. The research continues. Few later, new data showed significant better electrophysiological response in children with infantile ET, early operated comparatively with those operated after age 10 months. Which are my reasons for early surgery in infantile esotropia? Very shortly, I believe in better binocularity. I believe in better binocular visual field, because parents observed in 70–80% of my cases improvement of visual behavior of their baby, more interest for everything around them, less fear for new acquisitions as sitting, catching, or walking. a better appearance. Esotropia is subjectively associated in some cultures, including in our culture, with low intellect. So there is a chance for the parents to have a child who looks like the others. The satisfaction of early fixing this problem, something which worked wrong during the prenatal period. What do I think to be the reasons for late surgery in infantile esotropia? They are objective or subjective? I think they are more or less subjective because difficult strabismus deviation assessment is very difficult. Angle measurements, low cooperation, motility evaluation, refraction. Concern regarding general anesthesia, as you told before, at very young ages. Difficult surgery, small eye, long learning curve in post-duction testing, in surgery, fear of complication, post-operative poor control of eye scratching, eye drops or ointment administration, and poor outcome prediction, as all of you told before. Why these are not reasonable reasons for me? Because I think it's our fear which excludes the chance of the child to have the same eye alignment as a child with normal visual development during the most important period of the binocular development, meaning up to 24 months and essentially in the first year of life. The chance of a higher life quality for the child during the whole life, the child's normality and social integration, and also the parents' concern. You really don't know what you can get from early surgery in infantile esotropia if you don't operate it early. Thank you.
Great. Thank you, Daniela. That was awesome. You have laid down a very difficult argument for Kim to respond to. When you stop sharing your screen, we can let him go ahead.
Yes, sure.
You're getting voting right now online, and Kim, you've got your work cut out for you.
Thank you, David. Is that coming up? Good. Oh.
Yeah, it looks good.
Yeah. So thanks for asking me to contribute, and thanks, Daniela. I dare say I agree with you, but for the purpose of a debate, I have no financial disclosures, and I want to apologise to all those authors that you mentioned who have had terrific contribution to this topic. I don't mean to be disrespectful to them, but my plan is to stimulate thought and perhaps consider late surgery as an option. When you talk about early surgery, given we're hunting down stereopsis, this is from the same paper you showed me, we're really talking about what Birch and co-workers showed us, that the duration of misalignment is crucial. So what that translates to early surgery really means you should be operating very early, 4 to 7 months of age. I'm going to show you that late surgery is an option because there's all these other problems with early surgery. The first of all being the fact that there are consistent infantile misalignments that happen in normal children. Hord and co-workers and others have shown us that the significant majority of children show intermittent misalignments in those first few months of life. You don't want to operate in those children. CEOS, the Congenital Esotropia Observational Study, did have a significant proportion of children who got better. They were looking at this younger age group, right? 27% is a lot, and this paper is often used to help us identify the children, the 9% who they say, well, they're unlikely to get better. But I'll show you some numbers and you'll realise that that 9% doesn't look so bad sometimes. It's not the only paper. The ELIS study from Simons, which is an excellent study, they looked at an older cohort, which was looking at the young group being under 2 and the older group being from 32 months onwards. They still had a significant number of children who had spontaneous improvement. Right. Importantly, if you are interested in decent stereopsis, their conclusion of basic stereopsis was slightly higher, was higher in the early group. But if you're interested in good stereopsis, they only had 14 children, and the majority of that 14 actually were in the late group, not the early group. 4 of those children didn't even have surgery. Other problems arise. This has actually been mentioned already. Children with developmental delay, Jan mentioned this. Other issues, prematurity. They are a different beast. They don't follow our rules. And is it a problem? Yes, it's a problem, enough to be excluded from the CEOS study, so they're not looked at. It's a problem because at least half of these children have something else going on. So, and the problem arises is we don't make the diagnosis from 2 to 4 years of age. So now, when we see the young child of an infantile esotropia in the first 6 months of life, most of the time, the 50% who have something else going on, not prematurity, of course, but half of them won't be diagnosed for a couple of years, well past your choice of early surgery. This is a touchy subject amongst paediatric ophthalmologists, and Jan particularly, I'm sure. Does stereopsis really matter? This question has been asked for a long time, and for the interest of my 4 minutes, I'll summarise the increasing but small amount of literature. The answer is probably, right? But probably not as much as if you never had it. And we're not really sure how much you need to show a true benefit. We're also a world society, so we have to think just not in our developed countries. And looking for surgery in the first 12 months of life is often not realistic. There's different access to healthcare, health priorities in a family, cost of that, health priorities in a Ministry of Health for a country. And we mentioned anaesthetic care. Well, it is different around the world, particularly in the first year of life, particularly perioperative care. I've had the absolute privilege of working with a charity called Sight for All. And we go through many countries through Asia, and this is absolutely the experience we have found in Laos. Half the children have something else that we've operated on. And the average age of presentation, for many reasons, ease of access being one, but also the time they present, is at school age. The youngest we had was well over 1. So if I'm in my clinic in Sydney with a 4 month in front of me and an anxious parent asking me, shall we go ahead with surgery or Botox? In my mind I say, or I translate to the parent, maybe half the time the following numbers can translate. Surgical success with non-operation as high as 90% to get a 30% outcome of stereopsis, which probably is good for your child. That translates to a 13% success of a maybe. Lots of people aren't buying that. So my argument against early surgery is I agree with Daniela. Late surgery is easy to justify. We all want children to look normal. They want that. That's a 1 minute discussion with the parents. It's a lot more complex to synthesize the hopeful predictions of early surgery. Thanks very much.
Thanks very much, Kim. And Daniela, you have a chance to spend a minute or so responding.
Okay, thank you. Thank you to my partner for this very nice talk. Yes, I was sure that you will mention the study of Simmons, which actually is one of my friends. I'm not so sure that Europe is a homogeneous region. There are so different ways to look to this infantile esotropia, and in most of countries is operated late, not early. As in each country there are surgeons who operate late or early. So I don't think that without having I don't know, protocols for these studies. I know it's a good study, but I'm not so sure it's very relevant, because I saw some other studies for Adriano Mali, for instance, Italy, and his results show less surgery on children operated early than the others. So I appreciate all the data that you mentioned and totally agree that there are different countries, different ways, different regions. But my point is that if we can give a chance to the children, I'm talking especially children without developmental problems, and especially children with healthy newborn children. I think we have to give them a chance for an early alignment if parents agree, and if parents are coming early. And of course, here is another problem, the education problem, you know, but it depends on many factors. General practitioners, pediatricians, everybody. If the general practitioner says, oh, okay, this cannot be solved after 2 years and that's it, or it cannot be solved now, it's too early, it's too dangerous, anesthesia is too dangerous. So of course, this parent will be automatically stopped in this way to find a solution for his child. And I think
thank you.
A small piece of what I'm thinking about.
Kim, last words.
Thank you. Look, Daniela, I absolutely agree with you, and I think this is a debate, so I'm not meant to, but I do think you have the privilege sitting in a clinic room. We all have the privilege trying to synthesize all this data that the parents can't hope possibly to understand. And what we try and do is give them our best opinion and plan forward. I think your point about assessment of pediatric by the pediatrician is a good one, and it's certainly what I do in practice. Is I do ask a pediatrician to try and get ahead of those numbers where you have a surprise where there's something else going on. And if you can minimize that, I certainly feel more comfortable coming earlier. I think there's lots of reasons why you can be delayed, and most of them are logistics in reality. But I do like the idea that you say that should be our goal. We should start with the principle that we should try and restore a degree of normality, and understand that sometimes that's not possible and work backwards. So I'm not really disagreeing with you. I think you're spot on there, so thank you.
Thanks, Kim.
All right. Great. As not surprising, there's overlap in all of this. We're going to ask JR and Tony to weigh in. There's some things that came up. I mean, does stereopsis matter? How often are we going to, how early are we going to expose that tiny little brain to anesthesia and devastate their neurologic development by this early surgery? Are we not going to give them a chance to develop well late and operate on them late? These children, half of them have some sort of special needs problem. So all of this becomes an issue that we have to talk about. JR and Tony, you have your probing questions ready. JR, you want to go first?
Yeah, sure. Thank you. So I must say, at first hand, I worked with Herb Simmons for more than 20 years, so I'm totally biased on this discussion. I'm sorry about that. However, the early versus late surgery, some would consider the early surgery in that study wasn't really early surgery, it was already late. So, but still, having said that, I like the idea of Kim bringing in the problem with low-income countries, where it's really hard to get all these children in and do all the proper surgery on them anyway, and then it's better late than never. I think that, yeah, I must say what we know from the textbooks, that is what the risks are, or an indication for realignment in the very young period, 0 to 6 months, is a small angle. So if you operate on a small angle, you could either operate or wait and see. And this is exactly what the ALS studies also showed, that a lot of the people don't have to have surgery anyway. They realign spontaneously. So that is really the downsides, I think, of all the early surgery studies. And maybe we need to invest really in a proper upset or in a proper setup of these studies to look if it's really worthwhile and really be specific. But that will include that we can only allow just a fragment of the infantile esotropes with a larger angle than, let's say, 40 diopters. So I'm having second thought about that. And then it's also the neurologic development disorder that comes in. So this is really difficult. And how do you
Terrific. Tony, you're sitting in one of the great academic places of the world in Cambridge. We have doctors from, ready for this, Peru, Brazil, Portugal, Indonesia, Russia, Nigeria, Belgium, Israel, Greece, even the UK, Indonesia, Taiwan, and Kenya, who all want to know if you want to rip a child from their mother's arms when they're just a few months old and take them for brutal surgery, or if you can wait until they get a little bit older and not give them the best chance to succeed. Which of these negatives are you going to do?
Well, that's a really good question, Dave. I loved Daniela's concept that fear should not be a good reason not to operate early. That's a nice concept, but maybe some of the fear is appropriate, because I'm sure JR will help us here with trying to measure distance esotropia in a 2-month-old baby. it starts to get quite difficult. And in addition to that, the surgery. What are we talking about? Early surgery. And a lot of the studies, it's less than 2 years. I don't think any of us really think that's early. But we should be thinking about 2 months or 1 month maybe. In which case, how big is the eye? We don't know how big the eye is at 1 month. Only from cadaver studies from 100 years ago. So we don't know how big the eye is. We don't know how much to move the muscle. So there are these fears, maybe well proportioned fears. However, I think most of us can see that the earlier we get the eyes straight, the more chance we have of a stable outcome. And I think that, you know, different children have different problems, and we've already talked about the fact that this is not one condition, but it's more than one condition. But you know, we need to get in there early. We need some clever people to tell us how we do early surgery. You know, what's the easiest way of doing it? How much do we move the muscles? I don't know if there are any clever people out there who are going to tell me the answer to that. Because a 3 month
Tony, Tony, did I hear you just make the argument for early Botox? Is that because we don't know how much surgery to do, so just take a child at 1 month old and use Botox? Are you making that argument?
Well, at least with surgery, we can titrate it to some degree, but with Botox, unfortunately,
to what? Titrate it.
It's a one-off.
You're titrating it to what?
Well,
you don't know how much surgery to do. You don't know how big the eye is.
Yeah,
you have no way to titrate it.
Yeah, that's why I said we need some clever people to tell us.
But this is something all of us have been doing for our whole career, right? Children come to us, parents come to us, they're asking us for our opinion.
Absolutely.
I'm wondering if the rest of the panel wants to weigh in or have any comments. We're all practicing. What do you do? What do you think? Manoj, unmute.
So I do a bit of both. I do the augmented surgery. I do bimedial recessions, and I inject Botox at the same time. But there was some, in some ways, the botulinum modulates the uncertain part of the angle. And by doing bimedial recessions, you get some certainty from your result. So at the very least, you're correcting a certain angle. And if you overcorrected it with Botox, then the Botox will wear off over a period of time. But I think the points that were made were really good about how early is early. Are we really, 2 years is not early surgery. You really want to get very early. And I'm going to concede to Chong Bin that if you are going to operate very early, then there is a case to be made for using Botox perhaps, because it's a quick, easy procedure, short anesthetic, relatively forgiving. The only issue I have with early Botox, which Tony brought out and was brought out by one of the papers, is the incidence of ptosis and vertical deviations. That's a very highly amblyogenic age group, and that's my big concern.
So how big a deviation do you do augmented surgery on, Manoj? 30 prism diopters, would that get a bit of Botox? Or? So
I've got a series of about 45. I didn't include my own data in this because it was too short a presentation. But we're just in the process of writing up our results. And we've got about 45 patients where we've done augmented surgery, and we've got another 22 historic cohort where we've done bimedial recessions alone. My cutoff is about 40 prism diopters. So anything more than 40, I will augment. If it's less than 40, I'll just do bimedial recessions.
So again, I bring this into focus that there's a lot of research not only going into the age of onset, but maybe more importantly, the amount that the brain is exposed to the lack of binocular cooperation. So, for instance, in some of the forms of esotropia or exotropia in older children, Eileen Birch has shown that 2 to 3 months of a lack of binocular function could cause, even in adults, an irreversible loss of some binocular function. So I think that the variables that are involved in whether or not a certain intervention is successful really have to be streamlined. So as you mentioned, Manoj, if I just take 45 patients with 40 prism diopters, that could be 10 different diseases. right? So to compare them based on deviation alone, I think is continuing our ability to not get to the basis of knowledge over the last 130 years. If we just keep looking at deviations and not at the diseases, then we're not going to be any better than we are now in 50 years from now. I think that those of us that in our future colleagues, because many of us may be seeing the light at the end of the tunnel here, the colleagues in the next generation around the world need to try and understand how these patients are different from each other, so that we can characterize what our interventions mean.
That is very hard. That is very hard because the disease is so rare and it's so diverse. You would need the population of the world to do such a study, and it would be nice.
Jan, it's hard to go to the moon. It's not hard to do this.
Okay. Okay, but I really tried to include as many children as possible for the bilateral recession versus recession resection study, and in 3 countries, it took us 5 years to get 150 children.
Okay, I'm not saying we'd be hard, but it's not impossible.
Yeah, right. Well, JR, I think that I hear you volunteering for the World Society to coordinate the countries we have together. There are 70 countries listening right now to you. And as the World Society of Pediatric Ophthalmology and Strabismus, we can do that study. Manoj, you had a comment?
I'd like to comment.
I agree. This is an ideal opportunity. We've opened this forum up to so many colleagues around the world, many of whom have excellent ideas. And, this really makes the case for a collaborative effort.
Yes. All right. Thank you. Time to move on to the next session. Our next
Rich, while you're getting that ready, I'm just going to remind everybody about the Menti questions. We just did early versus late. Now, I'm just curious if there's any change in perspective after hearing the debate. It was overwhelmingly early was the more likely vote before the debate. And so far, it looks like early is still the overwhelming answer after the debate.
Thanks, Dave. Our next session is inferior oblique surgery during bimedial rectus recession, aye versus nay. And we will start with Dominic.
So, can you hear me?
Yes.
Okay, so that's it. It works. Yes, it works. So I would like to thank the board of WSPOS for this kind invitation to this new type of scientific communication. The question you asked me is, should we consider surgery of inferior oblique during horizontal surgery in infantile esotropia? This is a challenging question that I have to replace in the whole surgical strategy that I follow for now more than 25 years. And anyway, I don't know if you have to be for or against. As always, you just have to be thinking of the individual situation. I had the opportunity to moderate some roundtables during ESA congresses, and one was about infantile esotropia and another one about management of inferior oblique. Discussing with those all around the world experts showed that there were lots of disparities in the surgical strategies from one country to another, but amazingly, the overall results are about similar. If we intend to operate or not inferior oblique, I think that's it, yeah. If we intend to operate or not inferior oblique, we have to be sure that it is responsible for the elevation in adduction. If it is the case, it is associated to a large objective excyclotorsion observed in the fundus, but on the opposite, to fourth nerve palsy, there is no depression deficit and no abnormal head posture. The origin of primitive inferior oblique overaction in infantile esotropia is unclear until now. Upshoot in adduction may also be related to medial rectus that becomes elevator if the glove or the orbit are excyclorotated. And at last, it may also be related to DVD, usually associated with encyclotorsion, and also present in abduction. So the mechanism of the upshoot is not always easy to determine in very young age, and all the most in very large angles, as in this type of case. Although as all of us, I feel concerned by quality of life of babies and their families. I choose to avoid early surgery, as most of my French and European colleagues, for pragmatic reasons. We all know that esotropia and also elevation in adduction may spontaneously decrease during the first years. So there are medical and surgical drawbacks in choosing early surgery. Elsewhere, there is no real evidence of really better outcomes with early surgery. If there is a real parental pressure, I prefer practicing botulinum injection that may avoid surgery or at least decrease the angle until further surgery. And if early surgery is really needed, I would avoid operating the upshoot at the same time because it may modify with time. And as I say, its mechanism is not easy to analyze in very young ages. I usually indicate surgery after the age of 3 years, which is very old-fashioned, I see, when esotropia is more stable and easier to analyze. And I know it may be criticable also. I regularly perform inferior oblique surgery at the same time if its overaction is important, and I don't modify my intent in horizontal surgery. In the situation where inferior oblique overaction dominates the clinical presentation, as in this strabismus surso-adductorius, I will only perform surgery of inferior oblique and see what happens with the horizontal deviation. My team and I are currently publishing our long-term results of surgery tuned under and general anesthesia in infantile esotropia. So I checked the database. It showed that 40% of the cases were operated in the same surgery for both esodeviation and inferior oblique overaction. The results were similar in the two situations, and it shows that it is really possible to associate those two types of surgery. And as you can see, the mean age at surgery is 5 years old. To be totally clear, I would like to say that I only perform graded recessions of inferior oblique. It is tuned to the amount of overaction. I find it equivalently easy to perform as medial rectus recession and did not observe ocular complication. And I don't perform myectomies. I regret that it does not allow dosage and that it is really difficult to go back on it if necessary. So in conclusion, in my practice, inferior oblique surgery is easily combined to medial rectus surgery when necessary, but I remind you that I only practice late surgery and I only operate high-grade overaction of inferior oblique. Thank you very much.
Thank you, Dominic. That was excellent.
Dominic, yep, thank you for that. We're glad that you're able to join us today, and we're able to move this information from small regional association type meetings to a large world association. Meena, do you think that inferior obliques should be included in surgery?
Here I'm going to present my debate. Are you able to see my presentation?
Yes.
Are you able to see my presentation? Yes? Okay.
Yeah.
Lovely. First of all, thank you, David, and thank you, Ramesh, for the kind invitation. And it's a privilege to be here. So, inferior oblique surgery during biomedial recession? No. Well, first I placed a number one evidence-based argument, and someone already shared the excellent lecture, a Marshall Parks lecture by Lawrence Taxon, which has a lot of information. One of the most important things that they've talked about is about the prevalence of stereopsis, which we've been debating already. A lot of work has been done by Birch, Fawcett, and Steger, and you can see on the right that when you do align them early, less than 6 months, 74% seem to be obtaining some degree of stereopsis, and so on and so forth. Now, why am I talking about this? Well, there are even more papers. This one is from Turkey, and this was from 2014, and they seem to say the same things, that operate by perhaps 16 months. Now, the reason I'm saying all this is because I'm going to go back and refer to this paper, this landmark paper on primary inferior oblique overaction in congenital ET and so on, by Ed Wilson and Marshall Parks way back in 1989. If you look at the paper, it tells you that 63% were observed to have inferior oblique overaction only at an average age of 3.6 years, much older than what the age that we've been talking about that you need to operate to obtain stereopsis. Aha, you can see there in the top graph that less than 1 year of age, they really did not see much inferior oblique overaction at all, even though in a series of 158 or so, almost 108 patients got operated under 1 year of age. So fix what you can. Go ahead and do the bimedial recession or the augmented recession. You don't have to wait for the inferior oblique. Maybe it's not even there. Let's move on to argument number 2. You see this little kid here. Is this inferior oblique overaction or DVD or both? Because we know that the nose acts as an occluder. And so we go back to Marshall Park's paper again, and he says in the primary inferior oblique overaction was present, 45% had both IO overaction and DVD, and you can see figures for IO overaction alone and DVD alone. So are you really going to be able to tell the difference? Okay, if you look at the textbook, it'll tell you all these wonderful things that in which gaze you see the elevation, the pattern, hypertropia, and Herring's law is violated in the speed of the movement, and so on and so forth. Talks about encycloduction with refixation. But are you really going to be able to measure all this or examine and see all this in a little kid? So don't rush and do the inferior oblique procedure till you are sure. And there are still minor evidence-based little points, because if you go in and do unilaterally, 78% seem to develop inferior oblique overaction in the other eye. And the recurrence rate was about 20.5% in Marshall Park's paper. So, oh worthy opponent, I rest my case. Focus on the task at hand, which is the stereopsis. Thank you, and merci beaucoup.
Thank you, Meena. That was excellent.
Thank you.
Okay.
Go ahead. Do we have any, Dominique, anything else to say?
Well, I think we almost agree anyway, because I really agree on the fact that you have to be sure that the inferior oblique is really overactive before doing surgery on it. And I think when a baby is 1 year old, you are not sure about that. And even at 2 years old, you are not sure. And even when it seems to be unilateral, you may be sure that if you do unilateral surgery, it will appear on the other eye. So you have to be sure of the situation when you do that. And that's one of the reasons why I wait until 2-3 years before doing surgery. But when there is really an excyclotorsion, over elevation in adduction, that is really clear with the excyclotorsion of the fundus. Why not operating the inferior oblique? You have to do it, because if you don't do it, it will remain, and you have to do another surgery later. So that's why. But I wouldn't do it in young babies. I agree with you, and I agree with almost all of your arguments. Thank you.
Nice debate. Meena, do you have any last words?
Yeah, I just was going to add that it's typically in India, patients present later. We seldom see patients under 1 year of age. So we're usually able to examine them a little better. And so I actually do both surgeries together in most of my patients. But when Ramesh asked me to speak, I said, why not do a debate and look at the counterpoint and see maybe if there's something I have missed. So I was already in your camp, Dominique. So that's what I do. Thank you. Thank you once again.
I love it. Thank you both for laying out the gauntlet. I want you to know that as Dominique was talking, on the Menti voting, more people were saying inferior oblique surgery. Meena, as you spoke, it shifted. And so people are hearing and listening to the arguments. And now it's about 50-50 as we look at the scores on Menti. JR and Tony look like they were very anxious to jump into this. JR, one of the things I'd like you to touch on is it's come up in how can we even tell if there's true inferior oblique overaction? Can we actually examine these kids? Is it a DVD? Do we know what we're doing? Are we just, surgeons cutting away? What should we be?
Well, thank you, David. That was exactly my point. Because I've seen so many consecutive downshoot in adduction with an A pattern that I'm really eager and to teach my students to always do a cover test in left and right gaze and really make the differentiate between the a true overaction of the inferior oblique or the DVD, or as has been said, the combination of the two. So, and in order to do that, the patient definitely needs some kind of cooperation. You need cooperation to actually see the test results. At the other hand, I'm also anxious because we also saw that 3.5 years was about the age of the set off. So you want to make sure, because I think it was Guyton who also presented on that it's always the cause of the loss of binocular vision that these disturbances occur. So I would definitely also look at any signs of binocular vision that there were before the onset of this. So I think BV, binocular vision, and also making the measurements really appropriate to make a good difference between the inferior oblique overaction and the DVD, that's really important.
Tony, I'm guessing you have some thoughts on this.
I've got a few thoughts, yeah. The first thing, thank you for your talks, guys. They're very, very, very good. I was quite interested in Dominique's operating late anyway, so you have more of a chance to work things out. But the inferior oblique and DVD debate is more important, because I don't know what, I want to ask you, everybody, what your best treatment for DVD is, because I'm going to come clean here and say that my best treatment is inferior oblique anterior transposition. And the trouble is, if you've already gone in and done something to it, I don't think you can then anteriorly transpose it with any reliability. So I think that's another argument for not hitting the inferior obliques too early, because you might need them later down the line. I've never tried inferior rectus plication for DVD, which I see people are advocating nowadays, but I still think inferior oblique anterior transposition is the number one. I don't know, do you want to comment on how you treat DVD, Dominique? You're muted, Dominique.
So when usually the real DVD appears later, it appears after age 5, 6, and later. And even if you have performed inferior oblique surgery before, you see appearing this elevation, but there is no more the excyclo torsion. So I usually treat with the superior rectus, and personally I like to do the posterior fixation of the superior rectus. That works quite well. I don't know if somebody has really the perfect treatment for DVD that is really frequently recurring. But if you don't treat the inferior oblique, as you said, to keep the inferior oblique safe for a future surgery of DVD, you still have the elevation in adduction. So and this is present, and there is the excyclo torsion. You were talking about binocular vision, but how can binocular vision improve if you still have this huge excyclo torsion on the fundus? So I think it's part of the problem. If there is really an inferior oblique overaction, you have to treat it during the first surgery.
Yeah, we're back to the BSV being our goal. I don't know whether that's true or not. I just wanted to ask Meena as well. What do you think happens to A and B patterns when you do bimedial recessions? Have you got an idea of what?
Well, I think to some extent it also depends on whether there is a coexisting inferior oblique that contributed to the B pattern. And sometimes that is your tip-off. That is kind of your clue that maybe what you're dealing with is really inferior oblique overaction rather than just a DVD. But I want to answer to what Dominic was already alluding to. But by age 5 or 6, when DVD becomes more noticeable and becomes sometimes a social issue as well. And you're able to usually measure the children by then fairly reasonably. And then I guess you could decide whether you want to try and revise the inferior oblique recession if you have done it earlier to anterior transposition. I have only a couple of patients have done that. And you can decide based on whether your DVD measurements are more in adduction or abduction or the same, and then you take a call. But I would say the revision would be both revising the IOAT or maybe adding superior rectus recession.
Hey, Dave.
So I haven't heard anyone mention at all shifting the tendons, the medial recti, as you're doing your original surgery and leaving the inferior obliques alone, but still trying to address some over elevation and adduction and excyclotorsion. Anyone?
Dave, I just want to put a plug in very quickly. You can diagnose DVD and DHD extremely early in these patients with eye movement recording. So it's very easy. It may not be easy to do eye movement recording, but that's a skill that anybody can learn. Believe me, if I can learn it, anybody can learn it. But it's very easy to make a diagnosis of DHD, DVD with associated early fusion maldevelopment nystagmus in many of these patients if you use eye movement recording. So we don't have to depend on our fingers on the pulse of patients to make the diagnosis of heart arrhythmias in the same way we don't have to use our eyes and a paddle to make all the diagnoses of oculomotor. I think that the next step in diagnosing oculomotor diseases is a better investigation, not our own eyes and hands, but other types of equipment.
Hey, Rich, along those lines, and if I have you here, it would be a shame not to ask you this. Does any of what we've talked about today, early surgery, IO, when we get to the patient, affect the nystagmus?
Yeah, clearly all the data from 30 years show if there's an ongoing oscillation, improvement in binocular function in the cases with FMNS decreases the nystagmus tremendously. And those patients with either mixed or pure INS, the earlier that surgery is done, the more effect it has on the nystagmus.
Fabulous. We have a few minutes more for discussion, and some of the questions that have been coming in are really, really interesting. I'm going to look back. Our mentee vote at the end of inferior oblique surgery during BMR recession ended up almost exactly 50-50, just for the panel to know, because no one else is seeing that. It was very interesting. One of the questions that came in is the role of occlusion or patching therapy, either in conjunction with surgery or before surgery. This is open to all. How would you use that? Anyone want to take it?
I think it's required in patching. It's required to have an equal visual acuity before you even consider surgery. That's the way we do it, and it really helps afterwards to get a better alignment. So having your amblyopia treated before the surgery, I think is really the number one goal.
So, JR, are you thinking that you would delay surgery while you're waiting for the vision to become equal with patching?
Absolutely, yes.
And what happens if the manifest latent nystagmus is much worse when they put the patch on, JR?
Yeah. Well, that's a good point. And in my opinion, or what we usually say is that we patch a little longer, so it kind of disappears. So you're thinking of extending the hour. So in the end, so you see at first an increase of the nystagmus, and then when the patch is a little longer on, it disappears. But in most patients, it's doable. It's doable even with 2 hours. Mm-hmm. You see an increase, in my opinion.
Your observation is actually correct, JR. The nystagmus itself gets worse because of the decreased visual input, the afferent input. But once the afferent system improves, and that's been shown for a long time, that fusion maldevelopment nystagmus syndrome with the latent component will decrease as the afferent system becomes more symmetric or improves. I mean, you can see that yourself as you fog the eye. You can do that even in asymmetric afferent systems. If you start to overplus the one of the two eyes, the nystagmus intensity increases. There's a semi. It's not really a linear relationship, but there's definitely a positive relationship.
Is there a time frame for how long you patch when you have one of these very young 2-3-month-old children? Nobody knows how long they patch?
Well, it's on average it's a year and a half.
A year and a half that you patch until a year and a half?
No. Until the amblyopia completely disappeared. So it's a year and a half that you spend on patching. And some kids a little shorter, some kids a little longer. But it's a year and a half that you usually do your patching therapy to cure the amblyopia.
Would that include an infantile esotrope?
No, because they have this cross fixation. So if it's completely a normal kid with a cross fixation, they don't have amblyopia. So they just fixate that like this. You see them change their head, and they don't have any dominant eye and no amblyopia. But it's these accommodative esotropias or these microtropias that decompensate, that you find later have a very deep amblyopia. That in those kids, especially the accommodative esotropias, you spend a year and a half on average treating them before you.
Nina looks like she's going to jump through the screen if she has something to say.
I was just going to say, I don't think cross-fixation automatically implies there is no amblyopia. You have to, many of these kids can be tricky to examine. You'll have to ensure that they switch fixation at midline, because that's been my experience. If they don't switch fixation at midline and continue to follow with this eye into the other fields, then clearly there is amblyopia, and which needs treatment before you undertake any surgery.
Completely agree. There's definitely a higher chance of having an amblyopia anyway than a normal straight alignment, but still comparing to an accommodative esotropia, it's definitely less. But yeah, always check it, of course.
Can I say something?
I remember being at a social session at one of the APOS meetings, and Gene Helveston, if he's on, he maybe remember this or not, said when he traveled and did ophthalmology in some of the third world countries, and he saw all of the infantile esotropes who had no amblyopia due to cross fixation, he thought that maybe us operating on them early actually created a situation in which there were more amblyopes than if we left them with cross fixation and then straightened them older. And that was probably, he was talking to me about that about 25 years ago, I think.
I fully agree. They more often turn into a microtrope and have more chance of becoming amblyopic thereafter. That's one of the reasons why maybe in Dutch orthoptists and ophthalmologists don't treat them or treat them late, so they avoid of having them amblyopic.
Yeah.
Just to clarify,
Dominique?
to clarify a point. Sorry, Dominic, you go.
No, just to say that frequently if the children have straight eyes, the parents don't take them to the consultation, so they have no follow-up. So there is more late amblyopias. That's just the point. Yes.
Kim?
Yeah, I'm just concerned that our last 5 minutes may have been a little confusing. Can I just clarify for the audience, the vast majority of these children have a low risk of significant amblyopia when you're presenting your child at 2 or 3 months, and it doesn't usually delay our surgery. So we obviously, as Jan said, if we do need to treat, we treat, but the significant proportion of children we can get on and operate early anyway. But yeah, there's the rare child who has significant amblyopia early preoperatively.
So as we're getting ready to wrap up, are there any other comments any of our panelists would like to add?
Yeah, I wanted to say one last thing too. First of all, we probably should have got Dominic to talk about late surgery, not me. But that by the by, there's been a few comments about anesthesia toxicity and neurodevelopmental outcomes, and that's certainly something we all are very conscious of. But for those of you who are interested, you should. There's a great current opinion article by Ruth Graham a couple of years ago in Current Opinion of Anesthesiology. And it does highlight what Chong Bin said, that short anesthetics, even multiple anesthetics in the younger kids, there's not much evidence in big cohorts of studies on downside to neurodevelopmental outcome. Obviously, we have to be wary, and the GAS and PANDA trials have confirmed that. I just wanted to comment because there's been a few sort of negative comments about anesthesia in developed countries, and that's something we think of, but it's probably, fortunately, not as bad as it was the scare from 5 or 6 years ago.
Great. Well, this has been fabulous, and I think that we could go on for another 90 minutes, but our time has come to an end here at the WSPOS Episode 7 webinar worldwide. I can't tell you how many questions have come in. We've gotten many of them answered, but not all, and we'll be able to answer those afterwards. The panel has been phenomenal, and I can't thank you all enough for spending your time. For everyone, it's hard to talk for 4 minutes on a topic that we all could go on and on and on. So for the panel, thank you so much for all of your efforts. For our discussants, you guys were amazing. JR, you pointed out again why all of us surgeons need to have people who are thinking about the visual system the way an orthoptist does, and the important value that you bring to the table. Tony, can't thank you enough for your probing comments and questions. Rich, for your moderation and input, you're wonderful. And Todd, thank you for hosting this. For the administrators at WSPOS, thank you. For everyone else, if you want a certificate that you participated, please remember to go and take the survey that we have up. It is at tinyurl.com/survey.wspos. That's tinyurl.com/survey.wspos. You can get a participation certificate for joining us and help us also do a better job in the future. Don't forget that we have a Menti quiz coming up in August that we'll pit the world in different regions against each other. We'll have everyone answering some quiz questions. The webinars coming up next will be mostly towards pediatric ophthalmology and not strabismus, but we'll be back, don't worry. And look forward to seeing you at the WWW Connect, our incredible new approach to how to run a meeting that will be online and interactive. It's like nothing you've seen before. And that will be coming up also starting in August. To all of you out there around the world, to the 77 countries that have now participated today, to the nearly, I think it's 5,000 people out there, thank you so much for joining us. We look forward to seeing you again next week when our webinars will continue. Have a great day or a great night wherever you are around the world. On behalf of all of our panelists, thank you. Take care. Bye-bye.
Thanks, everybody. See you guys.